Can I request Dr. Som Shekhar, sir, to please welcome our esteemed faculty and participants and start the session.
Thank you very much. At the outset, welcome. I know that it's a little late evening, and most of the people have been working, and it's a quite tough day. But we have a fantastic academic session today. We have two fantastic international faculty who are leader and pioneer in their field. Then following that, we have very eminent panelists, Dr. Sanjay Sharma, Dr. Harit Chaturvedi sir, Dr. D.G. Vijay, and very nice real-time fantastic case to stimulate and have a fantastic panel discussion is going to be there. At the end of it, we are going to take a question and answer. After the two speakers, international speaker, we are not going to take the question because partly many of them might be covered in our panel discussion where both the speakers are part of panelists, and then we can have a good extended question and answer session at the end of it. So the first talk would be from Dr. Rishi Parameswar. It's my pleasure and honor to invite my very close friend and a very good academician, fantastic surgeon, a great friend of India and who bridges the Indo-UK Forum. He's a consultant oncoplastic and reconstructive breast surgeon in the University Hospital NHS Foundation Trust, Lancaster, UK. He's also the clinical lead in the breast surgery there, and he's also chair of the breast NSFG, the network group in Lancashire, and then he's also a honorary senior lecturer in the university. He's also the founding secretary and current president of Indo-UK Breast Forum, and he's a very good bridge between our Association of Breast Surgeons and then the Indo-UK. He's a great academician, an excellent orator, very good surgeon, more than that a very good human being. He has done vast work in reconstructive oncoplastic surgery, and he also holds a lot of national and international publications in various techniques. He's one among the principal investigator in very important POSNOC, LORIS, MAMO 50 trials. More than that, he loves teaching. He has passion for teaching. All my students who have gone to him and learning from him have fallen in really love with his skill and teaching. It's my great pleasure to invite him. He's also the convener of MCH Oncoplastic Reconstructive Surgery, where most of the Indian students are beneficiaries. And he's going to share his experience on what is the recent advances and how do we manage the axilla. Over to you, Rishi, and thank you very much for making time for us.
Thank you. Thank you, Som. That's very kind introduction. Probably more than what I deserve, but I'll take that on a Saturday afternoon. So my talk today is on axillary management.
So you can,
Kashish,
you can share slides if you want.
Can you put the
Yeah, so sure, sir. I'll just put the slide.
So it's an honor to be part of this webinar, Som Shekhar. Thank you very much. I think it's a bit of a rarity at the moment to talk about something which is not directly related to COVID. So I think it's a good change. So in the next 15 minutes, what I'll try to do is, can I change these slides myself?
So you can just, yes, sir, you can do that. So you can just move your mouse and then you'll be able to change your slides.
Okay, it's not doing at the moment.
Rishi, you can enter or you can click on the slide rather than the cursor. So
yeah, so there you go, sir.
Yeah.
Okay.
You can just make that full screen.
Using
so you can just use the arrow key and make it full screen. Yes.
Okay. All right. Okay. So in the next 15 minutes, I know it's a massive topic. What I'll try to do in the next 15 minutes is just touch on a bit of history as to where we have come and then what we are doing in the current times, and then what do we see the changes happening in the next decade or so. So the history which I'll always try to emphasize is that when we talk about evolution of breast cancer surgery, we always wonder why the de-escalation of surgery was quite a bit focused towards breast, and we saw from 1880s when the radical mastectomy started till 1950s when Bernard Fisher proposed his revolutionary theory, radical mastectomy was the only choice. And for the next almost 50 years, we focused the de-escalation on breast surgery. So from modified radical to breast conserving surgery. And those two trials, NSABP 06 and Milan trial, were instrumental. But then we gradually stretched our boundaries. Both these trials were for T1 and small T2 cancers. But we took liberty of extending this to T2 and even T3 tumors. And added to that, we started neoadjuvant treatments and then trying to conserve the breast, oncoplastic techniques for large cancers. And none of these actually were based on truly a randomized controlled trial. But the large series would suggest that they have acceptable oncological outcomes. But then we wonder as to why we never focused on axilla, because axilla remained for 50 years the same. It was the gold standard. And most of us know that till the dawn of the 21st century, axillary dissection was the only axillary staging tool. And this was despite the fact that the screening programs were introduced, and that led to about 33% reduction in breast cancer-related mortality in Europe and in America. We had better systemic therapy, early diagnosis, and lesser axillary nodal positivity, improving survival. And we were yet doing axillary dissection across the board at a very cost of morbidity. And then 30 to 40%, a lot of experts will say, is a very conservative estimate. If you look at all the problems these patients were getting, and there are studies to suggest that one problem or other from axillary dissection would be of the order of 60 to 70%. But it's not that we didn't have evidence to de-escalate axillary surgery. We did have that, the landmark NSABP B04 trial, which clearly demonstrated that adding massive radical axillary surgery didn't really lead to any survival benefit, or in fact, any regional failure benefit if you compare it to radiotherapy. So what happened after, basically these problems, improving survival and survivorship issue became quite important. And then we finally started looking at why we are not, focusing on axilla. And in early millennium, after these two landmark, 3 trials, sentinel node biopsy became the gold standard for axillary assessment. And it's quite important to note that all these trials had 10%, less than about 10% false negativity rate, and yet we didn't have any difference in overall survival or disease-free survival or regional recurrence. So these trials were quite important landmark, and then obviously led to more braver studies that started in the new millennium. So what is the current practice at the moment before we go to the shifting of axillary management scheme and the recent advances? We know that sentinel node biopsy is standard, and if it is negative, then we don't need to do any further axillary intervention. If the sentinel node biopsy is positive, and if it is 3 or more, it is generally accepted that axillary nodal dissection is the standard. But if we have 1 or 2 lymph nodes, then that is the area we will focus as to what has happened in the past 15, 20 years. And we'll address in the next few slides. If we have clinically positive axilla, then again, it is generally recommended, or the common practice would be that the patient has axillary dissection. But then this is also an area of huge interest, because we know that the survival is dependent on tumor biology more than just isolated axillary status. So in a low risk cancer, for example, luminal type cancers, what is the big deal if the axilla is positive? And the fact that ultrasound scans now detect even smaller metastases, to subject all these patients to axillary dissection is a bit unfair on them. Looking at all the evidences as to how a small volume axillary disease influence the survival and axillary regional failure. Not a lot has happened in that area, but the other area of interest, which is shifting the trend, is actually in the high risk tumor biology. And that means, triple negatives and HER2 positives and the use of neoadjuvant chemotherapy. And that has led to shift of the practice. And those are the two areas I'll be focusing on, because that's where the most of the studies have taken place lately. So what do we know? I know we can't go into the details of everything, but I've tried to put the summary as to what we know is quite established. So we know that micrometastases do not matter, and these two trials, Z11 and IBCSG 2301, they've proven beyond any doubt that micrometastasis does not require any further axillary intervention. Then we have the low volume axillary disease, which means 1 or 2 lymph nodes. And the Z11 trial was again a landmark trial without, accepting its limitations and some of the criticism it has. It's still a landmark trial. And then that basically opened the door for people to consider as to what we should be doing in low volume axillary disease. And it can be avoided. Now, the practice is not uniform across the world on this, and every country and every setup will have their own consideration, but it's certainly an important trial to look at as to how we deal with low volume axillary disease. The third important development in this millennium was obviously AMAROS trial, which showed the equivalence of radiotherapy to completion axillary node dissection at a 50% cost of the long-term morbidity. I'll discuss the post-neoadjuvant sentinel node biopsy issue a bit later. So for the moment, we'll move to the next slide. So avoidance of further axillary dissection in low volume disease. We know that there's certain criteria to it. It can only be applied to breast conserving surgery, and the whole breast radiotherapy is must, along with appropriate systemic adjuvant therapy. And in that, the fact that it didn't show any difference in overall survival or axillary recurrence has opened a whole lot of options and opened the door for a lot of patients who will be shown to have 1 or 2 axillary lymph node positive. But there are some criticism, some limitation of the trial. Number one, it's only been done on breast conserving surgery. There was issue of plenty of crossover, and the fact that the trial didn't achieve its intended accrual as planned. And also some issues about how the high tangent affected the axillary control as used in the USA. So there are further studies going on, and these 3 we will be looking at with some interest. A POSNOC, which extends the same study, basically extending to mastectomy 2 for 1 or 2 lymph nodes. And similar trials, SINOMAC and BOOG, they have the similar questions to answer. And I think once we have answer of these trials, which we would expect sometimes in the middle of this decade, I think it will help a lot of countries to look at the practices and make a definite recommendation in the low volume axillary disease on sentinel node biopsy. Uh, sorry. Now, the second change which happened is, not so, so long ago, we didn't have the option of anything if the sentinel node was positive. In fact, till the Z10 and IBSCG trial, we were doing axillary dissection even for micrometastasis. But to have an option of radiotherapy with far less comorbidity, morbidity resulting from it, compared to completion axillary node dissection, was quite an important development, in my opinion. And more and more patients now are getting radiotherapy for low volume axillary disease instead of axillary dissection. Having said that, we need to really take it carefully. AMAROS trial again has its own limitation, and we'll talk about that in the next few slides. But I think the AMAROS trial and the fact that we had an SABP B04 from 1971 to 74, that trial, one of the longest running trial, which hasn't shown any difference in survival or regional recurrence. There's plenty of evidence that axillary radiotherapy can be used for regional control effectively, and as shown by AMAROS, with 50% less morbidity. So how we talk about, I get this thing all the time when we have a talk as to how do we apply these trial findings to Indian context. Particularly, there's good evidence that you have younger patients, about a decade early, you have the peak, high incidence of locally advanced breast cancer, higher proportion of grade 3 disease, and all the other high risk factors such as ER negativity and HER2 positive cancers. I think it's not about applying it across the board. Medicine is all about informed choices and a frank discussion with the patient. I think if you look at the overall nodal positivity in India, I know it's about 50 to 60%, depending upon which study you look at. It can be applied to the lower risk patients. And even in the UK, of course, we have POSNOC trial going on, so there's a conflict, but those centers who are not participating in POSNOC trial, they are using Z11, but the ABS consensus is that we keep it for low risk patients. And that would be, postmenopausal, non-grade 3 disease, ER positive and HER2 negative. Now, I'm not saying that this is what you should be practicing, but I think this is one of the way of defining your population and which, what kind of patient you think you could apply this for. And if you save even a small minority of the patient, and I think survival isn't improving in India as it is elsewhere in the world, survivorship needs to be kept right in the center of the decision making. Now, the AMAROS finding and the regional nodal radiotherapy as a substitute to axillary dissection is an option, and we do use it. But again, I think it will be quite important that it is kept in focus that there are certain limitations of AMAROS trial. If you think about it, 70% of the patients in this trial were grade 1 or 2. And in fact, 80% of the disease, cancers were at T1. 40% of these patients who were taken as node positive had either micrometastasis or isolated tumor cell. It was only late in the trial, in I think 2008, they excluded isolated tumor cells and micrometastasis from the trial. So it's a big proportion of patients. So it should be, again, interpreted with some caution and used carefully when you decide that we're going to use radiotherapy as a substitute for axillary dissection. So that's basically the summary of what we're doing and what is happening in the low volume axillary disease. As far as what 3 or more node, the decision is more or less unanimous that he should offer axillary dissection if that's the case on sentinel node biopsy. If you look at the other group of patients where we have a higher incidence of nodal positivity and neoadjuvant chemotherapy now quite effective in triple negatives and HER2 positive cancers, we need to think as to whether we need to do axillary dissection in all these patients, or is there any way to be less aggressive with axilla. And this is where these 3 trials, which basically most of the trials related to sentinel node biopsy in a node positive, clinically node positive axilla, have shown that there's a high incidence of false negativity. And that's where the concern comes. And all these 3 trials, it's quite interesting when you think of Sentina or Z1071 or SNFNAC, they all had, in some way, very poor design. Not many of these trials didn't have even ultrasound mandated for preoperative screening. Dual technique was not mandated. So the conclusion from subset analysis from these trials was that if you're going to use it, use sentinel node biopsy in a clinically positive axilla after neoadjuvant therapy, then number 1, you should have a clinical complete response. Number 2, to start with, it should be a low volume disease. We can't apply this to a high volume axillary disease and expect that the sentinel node biopsy would be the right thing to do. And then if you have low volume disease showing clinical complete response, then yes, there is possibly a place for doing sentinel node biopsy, but it should be done with a dual technique, and at least 3 nodes should be retrieved. And that can achieve us the gold standard set by sentinel node biopsy, which is less than 10% of false negativity. It can be further improved by clipping and retrieval of the positive node diagnosed at the time of starting neoadjuvant chemotherapy. And the last bit, which is I think is still generally agreed, that if on sentinel node biopsy following post neoadjuvant chemotherapy for a clinically positive axilla, you need to do completion axillary dissection, even if you get isolated tumor cells or micrometastases. So the ITC and micrometastases rule elsewhere doesn't apply to post neoadjuvant because they have a high incidence of further disease in axilla. So again, we will ask that question: are we just talking, which is not relevant to Indian population? I think it is relevant. And if you think about higher nodal positivity with higher proportion of ER negative and HER2 positive disease, you would expect that a proportion of patient should be suitable for post neoadjuvant chemotherapy sentinel node biopsy, and maybe a higher incidence of a pathological complete response, hence saving them from all the morbidities from axillary dissection. And again, the same caution I've mentioned in the previous slide applies to these 2. I mean, it's quite accepted that if you have a positive axilla, then completion axillary dissection is optimum management. So I know I'm probably over my time already. The future of neoadjuvant chemotherapy and positive axilla, as we see, is we need more information, and these trials, which I mentioned, were particularly not robust enough for us to make a practice-changing decision. So there are a number of trials. I think in the UK we will be starting ATNEC trial where we will clip the positive lymph node before neoadjuvant chemotherapy, and the comparison will be made. But these 2 trials will also be important, and I think in the late 20s, we probably will have answers from these trials. NSABP B51 and Alliance 11202. The first one is clinically node-positive axilla, which turned negative post-neoadjuvant, either on sentinel node biopsy or axillary dissection, will be randomized to radiotherapy, to axilla and no radiotherapy. The second one, again, is probably even braver trial, is that we positive sentinel node biopsy, post-neoadjuvant, randomized to axillary dissection and radiotherapy or radiotherapy alone. So they all are indicating towards de-escalation of axillary surgery. And it's understandable. All these exercises we are doing and trying to do all these things about axillary management is basically to minimize the long-term morbidity from axillary dissection. But then who knows, we might have better imaging techniques available in future, and then we could make more selective decision as to who we offer axillary dissection and not. How do I see future of axillary management? Apart from the fact that already being set as a standard, I think globally we should see further de-escalation of axillary surgery in low volume axillary disease. And this probably will be helped with these 3 and then a few more trials to look at these important parameters of overall survival, disease-free survival, and axillary recurrence. I think targeted sentinel node biopsy is already becoming a practice in many places, even in the UK. And APNEC, as I said, will probably answer. This trial was due to start in May, but it has been delayed because of COVID, but will start sometimes later this year. And I think the possible major impact as to how we deal with the axillary disease post-neoadjuvant chemotherapy will come from these 2 important trials I mentioned earlier. And not to forget that we have discussed the nodal positivity in high-risk patients because by definition, most of these patients will be of worse molecular subtypes. But the other area, which is also an area of interest, is selective omission of axillary intervention completely. And then these 2 trials, SOUND and INSEMA, will probably answer those questions in the coming years. And I'm sure we will be more selective in choosing patients, even in low-risk disease, whether we need to do any axillary sentinel node biopsy or not. So, I mean, the key message from this talk should be that the general direction we are going is same as breast, from radical mastectomy to from maximum possible to minimum necessary, and the same applies to axillary dissection. And although it is not completely out, we should expect to see far less axillary dissection happening in the coming years, and hopefully minimize axillary morbidity further in the times to come. Thank you. Thanks very much. I hope I haven't taken too much of extra time here.
Thank you very much, Rishi. That's a very excellent compilation and very nicely evidence-based talk you put, especially coming from one among the main investigator of PASNOC trial. We are really looking forward for that trial, which is like, I initially thought the trial design was crazy, but it makes sense as the years are going and science is evolving. Fantastic talk. Thank you very much. And the questions we'll take in the panel discussion. We go to the next talk. It's my pleasure actually to, invite my very close friend, a great academician, and he's actually, fondly called as the walking encyclopedia. If you happen to just go around Pittsburgh University, and then people would call him, he's actually a teachers of teacher, and he's a walking encyclopedia. I just know in Pittsburgh McGill Hospital, if you happen to go and do a breast surgery fellow, you go to a breast surgery department or a medical oncology or a radiation, everybody would say, oh, where is Berryvall? Just ask him and he would answer everything. He is a radiation oncologist who got trained and then he did his residency from Philadelphia. He is a medical director of Maggie Women's Hospital. It's an exclusive women cancer hospital which deals breast and gynecology alone. It's a heaven to do either of the fellowships there in the UPMC Pittsburgh. And he's also a professor in the University of Pittsburgh School of Medicine. He's a director at large in the American Brachytherapy Society. He is a senior editor of International Journal of Radiation Oncology, and he has got a President Award, and consecutively he has been awarded Teachers of the Year for his outstanding teaching. People who just go and listen to Beriwal get mesmerized. He has more than 300 to 400 international peer-reviewed articles, 50 to 60 textbook chapters, multiple prestigious large volume research grant as a PI. It's honor to invite Sushil. And Sushil, over to you, especially when the FAST trial has come. You know, we moved from conventional 5 weeks radiation to 21, then 15, 1 week. Then, you know, it's like becoming like an APBI. So there's a lot for surgeon to learn. Better than from who? Sushil. Sushil, over to you. Thank you. Welcome.
Sushil, sir, you'll have to unmute your mic. We are unable to do the same. So can you hear us?
Yes, I'm doing it now.
Yeah, sir. You can just control the slides now, sir. You can just press enter. Yeah. So I'll just make the slides big for you. Yeah, go ahead, sir.
Thank you, Som, for the nice introduction. It's my pleasure to be part of it. And good morning, good afternoon, good evening, based on what time zone you're in. So Som asked me to discuss the recently published Lancet trials, but I will give our perspective of the whole breast cancer management. As you know, as we heard from the previous speaker, the idea of breast cancer management has changed. It is customized and individualized based on phenotype, disease type, and it's not one size fits all. And the goal of the treatments have been to de-escalate, less surgery for the axilla, less surgery for the breast, and less radiation, without compromising the outcome, but maintaining quality of life and making it easier on the patient. So, you know, like
so you can
I
just
always,
is
it?
Yeah, so there you go.
Good. So it's 25 fraction of historic value for early stage breast cancer. That's a question. And, you know, like, and at the end of the talk, you will be the best judge to make the answer. So, you know, like for a long time, breast cancer adjuvant treatment was between 6 to 7 weeks. 6 to 7 weeks. And based on some of the pioneering work done in UK, the fraction number came down from 6 to 7 weeks to 3 to 4 weeks. And now I'll discuss one of the recent data which has come out, like a 1 week treatment with and without boost, which will add another week to week and a half. At the same time, when the whole breast fractionation was changing from 6 weeks to 5 weeks to 1 week, the partial breast data also started to emerge. And I'll talk about some of the partial breast data where they do 1 week treatment or 2 weeks treatment or 3 weeks treatment. So the reason why 5 weeks treatment has become obsolete and it should not be done in 2020 for anybody with early stage breast cancer is because of 2 large randomized trials, one from Canada, one from UK. The Canadian trial was for low risk population and showed 3 weeks treatment is as good as 5 weeks treatment without the boost for the low risk population. While the UK STAR B trial was a much larger trial and it included all risk category in all age category. And again, they allowed boost. About 40% of the patients did get boost and did not show any difference in anywhere the breast cancer endpoint, whether they got 3 weeks versus 5 weeks with and without boost. But contrary to what people were thinking, the cosmetic outcome and the side effects were much less with the 3 weeks treatment. Less shrinkage of breast, less telangiectasia, less breast edema. So if you have a treatment which is cut short by 60% without compromising breast cancer outcome and causing less side effect, it's a no-brainer. That should be the standard of care. And that really changed the practice pattern across the world, although some people were slower to adapt than the other. But 3 weeks treatment became standard of care. Now the UK FAST trial, like they wanted to go even further to see whether they can cut it down more. So initially they did a trial with a weekly fractionation schedule of 5 weeks. So once a week times 5 weeks treatment. And they used two different fractionation schedule, which was 5.7 and 6. And they compared that, which when they started the trial, 5 weeks treatment was still standard of care. So they compared that to that. And they were basically looking at the normal tissue effect by looking at photograph and the cosmetic outcome. They updated the follow-up for 10 years. And at 10 years follow-up, there was no difference in any one of the breast cancer endpoint between the 2 weekly regimen of 5.7 times 6, 5 and 6 times 5 versus 5 weeks treatment. And when they looked at the cosmetic outcome and the late effect, the lower dose per fraction, the 5.7 gray was equivalent to 5 weeks. But the higher dose per fraction, 30 gray or 6 gray per fraction had worse cosmetic outcome. So they concluded that there is a fraction size effect and a 5.7 gray per fraction is equivalent to 5 weeks treatment once then weekly. But this was a fast trial. The treatment was still prolonged for 6 weeks, which is not very convenient to a lot of patients because they're still committed to 5 or 6 weeks. So this led to what was recently published last week in the Fast Forward in the Lancet. Among the pandemic, when people were trying to figure out what is the best way to shorten the course of radiation therapy for any disease site, because to make it convenient, available, and decrease the risk of infection or exposure to the patient. This trial comes out, which gives a different perspective of managing the breast cancer. So unlike
sorry to interrupt you, sir. Are you moving the slides? Because we are still on the first slide.
I am moving the slide.
So it's not moved, sir. Which slide are you on? So I can move it for you, sir.
Oh wow, it's odd. I'm on. So why is it not moving? I'm on the slide number 5.
So it's fast forward.
Yes.
Yeah. So just let me know. I'll just move your slide whenever you want to change the slide.
The one before. Yeah.
Yeah.
Yes. Okay. So what they did was they changed the fractionation schedule a bit more because it was condensed in 1 week. They decreased the fraction size a bit more, and they compared the standard 3 weeks treatment because by this time this trial was designed, 3 weeks became standard of care, and compared to 2 different fractionation schedules, both given within a week. So 5 days a week treatment, 27 gray and 26 gray, and they did allow boost because this was including a much wider spectrum of patients, like similar to the START-B. Anybody who needs breast only treatment, irrespective of the tumor size, age, or the grade. But odd part in the trial was the boost. Like even though the whole breast was hyperfractionated, the boost was still conventional fractionation, which sometimes defeats the purpose of shortening the treatment because if you're giving 8 fraction boost, you're treating the patient for another week and a half, which sometimes become counterintuitive to doing the hyperfractionation. Very important in the trial is the dose distribution, and these are sometimes hard to achieve. Because when you give high dose of fraction, there is more fraction size effect on the breast tissue. So you need to make sure your dose distribution is very homogeneous. And it's important for radiation oncology who's practicing that they do not treat with the same intention and goal as they did their 5 weeks or 3 weeks treatment. And the dose homogeneity is measured by a dose volume of 105%, 107%, 110%. And they had very strict criteria. And I can tell you, these are not easy to meet, especially if you're moderate to large breast size. You have to make a lot of adjustment to meet these criteria. The heart and lung dose, again, in the modern era, no beam should go to the heart. It's important when you're using this fraction size that you use all techniques to decrease the dose to the heart, and you use daily verification to make sure you're hitting the right target. So this is one of the recent patients we did with the Fast Forward trial. You can see it's a small-breasted woman, and it's covering the whole breast. But you can see the 105, which is the blue spot. Can you move the slide? Are the slides moving?
So the slides are not moving. I'll just stop sharing it. So would you want to share it from your screen?
Let me share it from my screen.
Yeah, you can do that, sir.
Let me share it.
So just one more request, sir. Can I request you to remove your backdrop? So it's moving a lot. So we'll just make it none, sir.
Okay. Let me share the screen.
Yeah, sure, sir.
Is the screen sharing okay now?
Yes, sir. You can go ahead, sir.
It's not changing. Are people able
to full screen, sir?
I did make full screen. Is it visible?
Okay. Yeah, perfect, sir. Thank you, sir.
Okay. So you can see that in the hotspot, the 105 is limited to a small part of the breast because if they're larger, then it can sometimes lead to more fibrosis and more toxicity. And some of the ways to decrease the heart dose is like we do prone breast, where the beam is outside the heart, or we use deep inspiration breath hold. On your left is the image without the breath hold. Right is the image with breath hold. You can see that by using the breath hold, the beams are going in front of the heart. So in 2020, when you're treating anybody with breast cancer, no beam should go through the heart. The mean dose to the heart should be 1 or 2 gray, and that's from the scatter and transmission. Directly, the beam should not go to the heart. That is unacceptable, because whatever small benefit you have in terms of survival, you negate that advantage by causing increased coronary artery disease. So it's important that when you treat this patient, we use all techniques, whether it's deep inspiration breath hold, conformal heart block, prone positioning, ABC, whatever is available to decrease the dose to the heart. And you can see the two techniques I've shown here, which decrease the dose to the heart. So in this trial, they looked at both patient-reported and a independent photograph assessment for the cosmetic outcome. And they compared with the baseline photograph. So the patient-reported was 4-point scale, and the photograph appearance was a 3-point scale. And you can see none of the breast cancer endpoints, there was a difference in terms of local control, regional control, distant relapse, breast cancer mortality, or all-cause mortality. They were all same, no matter what fraction size was used. But when they looked at the cosmetic outcome, again, similar to the forward trial, they did find there was a fraction size effect, which was surprising. A 1 grid dose made a difference, probably because of the sample size. So the lower dose per fraction, which was the 5.2 gray per fraction, was comparable to 3 weeks treatment. But a higher dose per fraction, which was 5.3 gray per fraction, was causing more fibrosis and worse cosmetic outcome. So they concluded that there is no difference in breast cancer control within 1 week versus 3 weeks. The lower dose per fraction, which is a 26 gray arm, was equivalent in terms of total dose. And they feel that patients, this should become standard of care. The only caveat is the follow-up was 5 years, unlike the forward trial, which had 10 years follow-up, or the START-B trial, which had 10 years follow-up. Now, when the whole breast fractionation was changing in UK and other part of the world, at the same time, there has been significant advancement in partial breast. I did not bring up all the studies, but I'm bringing up these 5 major randomized trials. The JACASTRO is a European trial for predominantly low-risk population, comparing whole breast to brachytherapy. No difference in any endpoint in terms of local control and toxicity. The RAPID trial is the Canadian trial for low-risk population. No difference in breast cancer endpoint, but the partial breast using 38.5 in 10 fraction caused more fibrosis and poor cosmetic outcome than the whole breast. The IMPORT trial is a UK trial, which was comparing 3 weeks treatment to the whole breast versus 3 weeks treatment to the partial breast. Easy technique, tangential beam. No difference in any one of the breast cancer endpoint, but there was difference in toxicity. The partial breast had less toxicity. The Florence trial again compared 6 weeks treatment to a partial breast 6 gray times 5. They reported 10 years data at San Antonio. No difference in any one of the breast cancer endpoint, but less side effect in terms of fibrosis and cosmetic outcome. And B39, which is a North American trial, which we did participate, is the largest of these 5 trials, included all risk categories. The trial was designed to show non-inferiority of partial breast, but unfortunately showed small difference. It was statistically significant, but we don't know whether it's clinically significant or not. And they allowed high dose rate and 38.5 in time, and they saw no difference. So you can see these 5 randomized trials showed that at least in 4 of them, for the low-risk population, there is no difference in partial breast and whole breast. There is difference in toxicity depending on what technique you use. So this is the Italian trial, 10 years update at San Antonio, 500 women with low-risk population, 40 and above, comparing 5 weeks treatment followed by boost to 5 treatment partial breast every other day. This is how it is done. Like you can see, the target is focusing on surgical bed with a margin of about 2 cm or so. And you're sparing the other part of the breast tissue. So this blue is basically corresponding to what you're treating. It's a multi-beam IMRT technique and IGRT technique, a bit more sophisticated and a bit more complicated. But you can see you can spare the uninvolved breast tissue. There is still some dose to uninvolved breast tissue. And that's why for this technique to be viable, you need to have a breast to cavity ratio of about 25 to 30%. Like if the cavity is too big with respect to the breast size, then it becomes harder to achieve. And again, they showed no difference in any one of the endpoints for breast cancer at 10 years, 3.9 versus 3%. Excellent cosmetic outcome, more so in the partial breast arm. The partial breast arm had higher likelihood of excellent cosmetic outcome in comparison to whole breast. So in conclusion, I mean, this is my take on the practice pattern for early stage breast cancer. This doesn't include node positive. This doesn't include, post mastectomy. That's a different discussion. For all patients with breast cancer, should be 3 weeks treatment followed by boost. Nobody should be getting 5 weeks treatment followed by boost. That's an obsolete thing. That is in modern era that should not be done. For the low risk population like 50 and above, grade 1, grade 2, low genomic score and node negative, at our institution, if they're technically suitable, we do partial breast using Italian trial, 6K times 5, using IMRT and IGRT. But if they're not suitable for the Italian trial, then we consider the import trial, like 3 weeks treatment, 40 grain, 15 fractions. And now with this trial coming out, probably we'll be starting offering this 5.2 times 5. For anybody who needs boost, we still continue to use 3 weeks treatment followed by the boost. But very important, no matter what fraction you use, what technique you use, the dosimetry has to be strictly maintained in terms of dose homogeneity, in terms of dose to the heart, and in terms of dose to the lung. If you don't do it right, no matter what fraction size you're using, you're not doing service to the patient. So with this, I conclude my talk on this so-called short course of radiation therapy with the idea that conventional fractionation is historical significance now for breast cancer. The so-called conventional fractionation should be the hypofractionation, and so-called hypofractionation should be the extreme hypofractionation, which is the fast-forward trial or the partial breast. Thank you.
Thank you, Sushil. That's an excellent talk and very authoritative. We are almost seeing de-escalation of treatment and radiation, and this would really be exciting, and especially for a country where logistically challenged, and most of the women don't opt for breast conservation because they can't stay for another month in a metro city and take radiation. This would be fantastic, and even more interesting is the cosmetic part. That's excellent talk, and I thank on behalf of OncoStem and everybody for an excellent talk. What we will do now is we'll go to the panel. So I have, and then both the international speakers are also part of that, and at the end of it, we take question and answer session. We have three eminent, my very senior colleagues who are almost like teachers of teachers, with whom hundreds of oncologists have got trained across India. Dr. Sanjay Sharma, who is the Director of Thoracic and Breast Division, Asian Cancer Institution and Bombay Hospital Research Center. Dr. Harit Chaturvedi, who is the Chairman, Director and Head of Max Cancer Center, and a very senior colleague and well-known, renowned surgical oncologist. My very close friend and colleague who hails from my state, but somehow has gone and loved and settled in Gujarat, Dr. D.G. Vijay, who is one of the Director of Breast Surgery Services at HCG Ahmedabad. What has happened is very good, interesting couple of cases has been given by them. And then we'll sort of discuss it and take the theme and an opinion from everybody. And then we go ahead with question and answer session. So this is the first case study Dr. Sanjay Sharma gave. Actually, he was supposed to join us a little late. Sir, can I request, since you are there and this is your case, is it okay you take us forward through that?
I don't think this is the case that this was a locally advanced. I don't know how did we get that. You didn't see this?
Yeah.
No, actually, I sent one early case. This was, I don't know. I think there's some mix up there. So,
no, sir, only the photos have come from the last case, I think, but case one, which you
I think this is a locally advanced. I think you got a wrong slide, pedophile. Unfortunately, I don't know how to put it back. Let's go for the second case. You have any other case or something else?
Yes, sir. What I'll do is we'll put this case and we have second, third of your case. This is one of your case which you gave.
No, but this is a locally advanced. I don't think I meant to use this because I have a lady who is 42-year-old female, unmarried, with high family history, and had a large breast, had non-palpable breast cancer, and had a small lesion. No, I don't think that is the reason. No.
Sir, just check that. Is this the second case?
I don't think that's the case.
I'll put it. I'll put this case. Just check that.
Okay.
Yeah. Is this the case?
I don't know. No. This is not. No, I don't think this is.
Yeah, we read 3 cases from you.
No, I think they are probably wrong set of slides. I don't know. Okay, you go ahead and present.
Yeah, you can present a 38-year-old premenopausal young lady. Yeah.
Anyway, I think there's some confusion there. I sent different cases. couldn't check it. I'm sorry, I was busy, so couldn't do that.
No problem. Because I just went through them. They are in the line. I will put this case and then we'll take this up.
Go ahead. Because since the topic was early breast cancer, I didn't include metastatic cancers at all.
Okay, so we see this particular case. Anyhow, see, this is one of the case which I received from him, which I went through and I can present it. It's
Please
a
go ahead.
lady, 34-year, who had a right breast lump for months, and it's about 4 into 4 centimeter forminard and an axillary lymph node. And then the node FNA was positive, and then the core biopsy done actually shows a ER positive, PR positive, HER2 3+. And then a MIP score was 50%, and then androgen receptor. Can I just ask at this point, sir, routinely you do androgen receptors in the institution, and then Harit sir and DG Vijay, do you now have integrated androgen receptor in your routine panel?
Sanjay sir, you'll have to unmute your mic.
That's on you from my mind. It's done already.
Yes,
Yeah.
sir, it's audible. You are audible.
It's done. Okay. It was done for me. So what I have been doing a study especially for practically all the cases who are ER/PR positive and even triple negative cases, because I believe that there is something to do with AR receptors for prognostication in future. And maybe we have now embarked upon certain studies in our cases that we have in more than 70 cases. My own fellow and breast colleague now with us, Dr. Vidhi, is doing this study on following up of these patients with AR positive, high PR, low ARs, prognostically. I believe that high ARs are the ones who have a relatively better prognosis in this group of patients, especially if you are HER2 positive or a ER positive. So it has fairly meaning if they are BRCA negative, AR is certainly a very good marker, especially if in India when you cannot get other molecular markers done for triple negative patients.
Okay, Dr. Harit and DG Vijay, do you now started routinely integrated androgen receptor in your cases, or you just do it in triple negative?
Only on relapse and in triple negative, yeah, not upfront.
Fantastic.
Not
And
correct.
DG, you agree with the same, and this is what's your practice?
Absolutely.
Okay, Sushil, in UPMC Pittsburgh, has it been included into the panel routinely?
So, like for some triple negative, they do it, but it's not being used for management purposes because we don't have any outcome data to support what to do. So sometimes they use it for metastatic disease setting if there is triple negative to see if they would be eligible for some clinical trial. But currently we do not know how to interpret and use the data. So it's not being routinely done. But in some triple negative patients, two things are being done. One is the AR receptor, and nowadays even PD-L1 expression.
To clarify,
Yes, sir.
as I said, we are on the job at the moment. Maybe in another 1 year's time, I will have some kind of result for more than 400 cases that we have studied. And probably it will give you a good answer for Indian patient at least. So
I agree with you, sir. There was also a paper from Rajiv Gandhi from Dowell's unit, and this is something which is coming up. Now, coming back to this particular case, it is something which is locally T2 lesion, but on a workup was found to just have a bone lesion. So the issue is on textbook HSCC edition, it becomes a metastatic breast cancer, but it is an oligometastatic disease.
absolutely, this is an oligometastasis disease. Yes.
So I would just want to take an opinion from all the panelists, Harit sir and Rishi and DG Vijay. What is the message you want to give to the audience? So good old times, stage 4 palliative, or you would take it oligometastasis and we go ahead with curative intent?
I think
Now I'm unmuted. Okay. Yeah, Dr. Vijay.
oligometastatic disease, she is hormone receptor positive. I think she is likely to have a good outcome and she should be treated with a curative intent.
Now, how do you sequence it? We agree. So, if you have an operable primary and a oligometastasis, so you would go for a surgery first and then follow it with systemic therapy, or you would believe that at stage 4 there is micrometastasis in the blood, so start with systemic with keeping an option of local-regional treatment once they respond. So, what
Start with systemic, yeah. So Somsekhar, start with systemic and then go on for local regional disease management.
Okay, so Rishi, would you, is that the philosophy you would do, or you would do something else?
Very easy decision. We'll start with systemic therapy, and I'm sure she's HER2 positive. So, I mean, it's not like you are positive in HER2 negative disease, oligometastasis. You should consider her still a high risk, and a systemic therapy and monitoring the MET. I don't know how conclusive is that, but to monitor it and then do surgery post systemic therapy.
That's absolutely right. You know, there is already a question, people telling like, you know, what would you take as oligomats? A single site but multiple confined to one, or multiple solitary? These are the very beautiful slides which Dr. Sanjay Sharma has given. The state of limited systemic disease with a local treatment is possible curative, and the purpose of treatment is this. And this is one European definition which Dr. Sharma sir has given: 5 metastases in each, less than 5 centimeter, 2 organ apart from primary. American definition: 4 mats, not more than 2 organ. So sort of, you know, this is a gray area, but nevertheless, European American definition, what Sanjay Sharma has given, is something which we would take it up. And this is the oligometastasis, you know, sin oligometastasis and metachronis, you would say. And this is something which is the rationale of the treatment. Usually oligometastasis helps if you have a estrogen receptor disease. Typically a estrogen receptor negative disease is something which we would not take, and in this particular area, multimodality treatment and not denying local regional treatment is something which is very, very important for us to know. Like in this patient, you can see that had a local regional treatment also, and then patient had a neoadjuvant, and then patient had almost a pathological response. Some of the most important thing is when you treat them like a oligometastasis, local regional treatment would be same as an early breast cancer, which would not deny. There are a lot of evidence. There are 2 randomized trials which has come, and there is one practical consensus statement which I had co-authored with a lot of my leading people, which we published in SJJC journal. In nutshell, if you see, there is one randomized trial which was a Turkish trial, which was a positive trial, which showed there was a survival benefit in oligometastasis. And there is another trial which is from the India, from Tata, which showed there was no survival benefit. So nevertheless, out of the 2 randomized trial, there is an evidence that if you have a ER positive patient, oligometastasis responding to systemic therapy, preferably estrogen receptor positive, local regional treatment, breast conservation still acceptable, same margin negative, and radiation has to be done. So this is essentially the trust of both of them. I would request Sanjay Sharma and Vijay and Hari sir, anything else you want to add in this particular area, or any message you want to give to the people, when to do, when not to do local regional in oligometastasis?
Yeah, I think that you have to really see the biology of the patient, the age of the patient, and obviously the disease location. For example, if you have a solitary brain met and a small favorable biology tumor, you can definitely go ahead and give upfront therapy, or even you can do a radiosurgery for a solitary brain met. And nowadays, with fantastic results that you have without causing any sort of cognitive functional deformities to the person concerned, or a solitary bone met in the spine, or a solitary met somewhere else. So give upfront therapy depending on the biology as in this patient, and then subsequently you can go ahead and resect. We have had also a patient who had primary treatment, and we had 2 or 3 lung met which we have gone down resected, and patients are almost surviving more than 4 or 5 years. So definitely a biology plays the main role, and you have to understand that yes, these kind of patients definitely would do well. However, probably scenario would change in a case of breast cancer, especially in ER/PR with availability of CDK4 inhibitors. So probably in that case, much of surgical intervention may not be necessary at that moment, depending on the ER/PR positivity and site of solitary metastasis, which may just disappear with a CDK4 inhibitor.
I think it's also important to bear in mind that doing surgery, offering surgery in this 38-year-old is really, it should not be a question whether she should be offered, because surgery still offers the best chance of a local regional control. So I don't think not offering surgery to this particular patient should be an option.
Presented the two randomized data. I want to bring up two more things. There is one large series from MD Anderson only looking at HER2 positive breast cancer with stage 4 disease, like this patient. And they reported 10 years disease-free survival in the study. When they looked at the variable which predicted for the outcome, other than the solitary mets, oligomets, and bone-only disease, one of the variables which predicted for the long-term outcome was surgical intervention. So in the era of targeted therapy for HER2 positive breast cancer, it's kind of routine to treat them with upfront chemotherapy and offer local treatment. And coming up ASCO, they are going to present the ECOG trial, which is a US trial of local treatment. It's one of the plenary sessions. We'll see what the results of this ECOG trial are. But they're going to present the ECOG study, which was also evaluating the role of local treatment in stage 4 breast cancer. Currently, the data is mixed. But you have to look at patient, look at the response, and make a call. But anybody who has a target, whether it's ER positive or HER2 positive, is a potential candidate.
Good. Sir, Harith sir, there are a couple of questions pertaining to this from a lot of people. Number one, local treatment is breast conservation acceptable? Number one. Number two, would you still offer SLNB axillary treatment because with metastatic, but still we do axillary treatment same? Third, does the general principle of radiation adjuvant remains the same?
Thank you very much, Somsekhar, for all these three questions. So number one, as far as conservation versus mastectomy is concerned, I think the gold standard is that we have, wherever possible, do conservation. However, if you have a bulky primary T4V disease to start with, in those cases, we don't offer a conservative procedure even after a good response. Otherwise, T2, T3 disease, wherever conservation is possible, even with M1 disease, we go ahead and do a conservative procedure. For axilla, as Sushil also said, that post neoadjuvant, I think Rishi was talking about, post neoadjuvant treatment, we should be very cautious in doing sentinel node sampling. So all these patients should have a proper axillary evaluation with ultrasound upfront also, and subsequently axilla management will be level 1 and 2 properly done for M1 disease, those who start with M1 disease. And as far as radiation is concerned, the local treatment has to be complete. So it's, whenever you're talking about local control, it has to, indications have to be same, that we have to go ahead and do radiation also and complete the treatment.
That's fantastic. See, in summary, if you look at the two trials, the Turkish trial and the MA and the trial, bone alone metastasis favorably, very good. Lung alone match, very good. ER positive, excellent. These are the patient, and if they are not synchronous but metacoronous, a good DFS is very good. So these are the patient where the local regional treatment guidelines remains the same. I have one fantastic case from Sanjay Sharma. A operable early breast cancer with one solitary node in the axilla, which is ER negative, PR negative, HER2 negative, triple negative. So here the only thing the patient presented was a nodule in the lung and then the brain. So suppose if we have it, is there any condition where loco-regional treatment would take precedence in oligomats over systemic therapy? Like, would you, suppose you have a solitary liver lesion, would you do RFA first? Or if you have a solitary brain lesion, you would do SBRT first and then go for systemic therapy? Are there any exception where loco-regional treatment could be taken first in oligomats?
So as far as SBRT for brain is concerned, you may consider symptomatic patient. But as far as loco-regional treatment for breast is concerned, it should be always be systemic treatment followed by local treatment for the breast. If suppose the brain lesion is causing some symptoms, in that case, you can consider some treatment for that.
I mean, to answer to your question, like response to systemic treatment is important to decide breast treatment. But that being said, if they're symptomatic from metastatic disease, then you would do it.
Absolutely.
And for CNS lesion, because chemotherapy doesn't cross blood-brain barrier. So anytime you have a CNS lesion, whether you're symptomatic or asymptomatic, we'll address with surgery or stereotactic or both, depending on the situation.
Okay, so this is the metastasis theory. So the bottom line is oligomats, ER/PR positive, bone alone or lung alone, or fits into American, European, systemic therapy, original treatment would still be a curative intent. Sir, Harith sir, you wanted to add something?
No, I said initially what I think Dr. Sushil mentioned, that If it is symptomatic brain met, then you go ahead and treat that. Otherwise, always systemic treatment whenever, even if oligometastatic disease.
Thank you.
One more point, Som, I would like to point out that anytime you have oligomets, and I don't know these two cases you presented where the biopsy was done or not, we do not rely on the imaging to call them oligomets. Tissue diagnosis is very important because that changes the prognosis of the patient. So you may not change the intent of the treatment, but the outcome is different. So whether it's solitary lung mets or a bone mets, we will always establish with the biopsy.
Okay. Sir, I would now invite Harit sir to present this case. It's a fantastic case, so you can take over the screen, sir.
Sure.
Ashish, please give the screen control to sir and unmute all the panelists.
Yeah.
Sir, all the
Can I move the
panelists
slide?
are
Yeah.
unmuted, sir.
Okay.
Even
Thank
Vijay sir, your this thing is unmuted.
Okay,
Yeah,
this is a 69-year-old lady who had history of breast cancer in 2001. She was treated with conservation with axial lymph node dissection, T2N0, ER/PR positive, had adjuvant RT and tamoxifen for 5 years, and subsequently was on follow-up. 19 years later, can I have the next slide, please?
Yes, sir.
Yeah. So in March 2020, that is 19 years later, she complained of heaviness in the breast. On examination, there was a vague lump in the right breast near the previous scar. Operated breast, axilla, everything was fine. So on ultrasound, there was 2 into 2 centimeter lesion in the right breast, upper central quadrant, no axillary nodes. And on mammography, it was BI-RADS 4C. Next, please. We did a mammogram and an MRI. This was the lesion somewhere. Next slide, please. Actually, the MRI. So this is where on the MRI, you could pick up the lesion, the right breast, upper central lesion, 2.1 into 2 centimeters satellite nodules. You can see a few satellite nodules nearby. And this is the lesion. We biopsied that. Next, please. Yeah. Biopsied that. It was grade 3. Ki67 was 20%, ER/PR positive, HER2 2+, which was negative on FISH. So this lady was very keen on conservation. That was one thing. We offered her surgery upfront. We offered her mastectomy. She was very keen on conservation. Or she said, if we have surgery, then we could go for reconstruction. That is fine. But in view of COVID, because by this time she got diagnosed, COVID was very much there. And unfortunately, her brother in UK subsequently died of COVID. He was a CKD patient on dialysis and he died. So she just did not want any surgery. She chose to have neoadjuvant hormone therapy. However, she was very anxious about her disease status and possibility of meds and all that. So in that case, next slide, please. We discussed with her, started her on hormone therapy, and letrozole was started. She still was very anxious and coming on every week. She was coming back to us, what to do, am I safe and all. Finally, she got an oncotype done on the biopsy sample, and that score has come as 25. So she is already on 4 weeks of AI taken. So now the situation is, what should we do? Should we continue with hormone therapy? Should we switch to chemo, or as planned earlier, we want to still go ahead with surgery? Next slide, please. We have yeah. So this is the case which I want to discuss.
This is something which we say, things were going very well, and suddenly we did a genomic analysis.
Yes.
And now, having asked for it, having looked at the evidence, now we are in a crossroad.
So her first surgeon was in Switzerland, so she was in constant touch with them. That person recommended for KI and then genomic, and the score came bang 25, and we didn't know what to do. So anyway, she's continuing on hormone therapy, but I think it's a good case to discuss how we. So my take is that surgery upfront is the most important thing, because this is a case, she's ER/PR positive, HER2 negative. We had offered her surgery. She doesn't want surgery at least for the next couple of months. And so meanwhile, we are continuing on hormone therapy. But this score has got everybody worrying.
I want to bring up one point, even though, yes, mastectomy is standard of care, but there is data emerging for re-radiation therapy and repeat lumpectomy in patients who have recurrence of new primary in the same breast after lumpectomy radiation. The optimal candidate is long duration, ER positive breast
long
cancer.
Duration, 19 years, yeah.
Long duration, preferably ER positive breast cancer, preferably a good cosmetic outcome for the previous treatment. If all those 3 criteria are met, then if you look at a phase 2 study, which the RTOG did, where they treated these patients with re-radiation therapy, and they used a different schedule. It was partial breast, not whole breast, because you can't do whole breast, and partial breast twice a day for 3 weeks. And they looked at the cosmetic outcome in ipsilateral breast tumor recurrence at about 5 years. We don't have long-term follow-up. The numbers look promising. The ipsilateral breast tumor recurrence were in single digit. Cosmetic outcome was good. And subsequent mastectomy was only done in 10% of the patient, either because of choice of the patient, we change after lumpectomy radiation, or they had some complications. So I think, even though we always say the book teaching is if somebody has lumpectomy radiation, standard is mastectomy, but that's changing.
Yeah.
There are options, and it's driven by the patient and driven by the disease.
I have two questions for you, Dr. Sushil. One is that her skin doesn't look very good. So that was one reason why our radiation oncologist was slightly concerned. And second question is not directly applicable in this case, but suppose there are two lesions in two different quadrants, and both are good, possible to do offer cause. So we had a similar such a case about 2 months back, and that lady was very keen on conservation.
So
But we were very hesitant in
the second case was recurrence or the first time?
No, this is the first time, two lesions in two different quadrants,
Sure.
both around 1.5 centimeters. That is one. And second, in this case, the main concern for radiation oncologists was the skin texture was not very good. They were saying that this is.
So if the clinical call is that she has side effects from the previous treatment, which will get exacerbated, then that changes things. So that's a clinical call. But to answer to your second question, classical teaching has been a multicentric disease and indication of mastectomy.
Yeah.
But all that data on multicentricity was done in the time period when imaging were not good, like MRs were not available, digital mammograms were not available. Is the risk of ipsilateral breast tumor recurrence same in the modern era? It's not known. AKSOF did a phase 2 study. We did participate in that study where people who had two-side lumpectomy got radiation therapy. It's a phase 2 study. Its study is closed now, and we'll have the outcome data in 5 years to see what the risk of local recurrence is. But the retrospective data suggests that two-side lumpectomy doesn't have the same recurrence rate as was reported in the past, like 25-30%, because we are able to demarcate those two sites much better. And we are finding those two sites more commonly now in the MR era. So it is considered relative contraindication, but the data is emerging and things will change.
Thank you.
Can I intervene here?
Yes, yes.
See, I have a little reservation about the Oncotype DX in this scenario. Because of probably, you must understand that the whole breast has already been radiated. I don't know really the pathology or, you know, the newer lesion would be the same as what probably a de novo primary lesion is. So I don't think anywhere in the world they would compare an Oncotype DX in a post-radiation recurrence vis-a-vis it is.
I think Oncotype or Oncostem and
I'm talking about Oncotype.
is about
Sorry,
the tumor.
Oncotype DX.
It's about the tumor. So I would not give too much importance on the previous history. I will take the sample and evaluate that just as any de novo case I would evaluate.
No, but that is my little question. So because see, you are at the cusp. See, you don't know. You're still in. That number. Forget that number. The value of the test remains. That's what I'm trying. I'm not denying that. I was wondering whether this changes in this thing would alter the Oncotype DX a little bit. Because
that is about the tumor. So that's what I'm saying. We should not confuse the value of the test because of the previous history of radiation. That's what I'm saying.
And secondly, she's on the cusp of even if you take a TANDREX-2 trial, it's 25. So, I mean, you're right in the country. So I would agree with you that we should upfront operate. But at the moment, with this present scenario, we would continue to give the tamoxifen for whatever it is worth it. And then ultimately, you have to operate her and put her on some other kind of therapy depending on the final histology report.
I agree. I just want to also bring to notice of all the participants, you know, we have very high number. Of the two trials which was published in year 2018 in St. Helens, suppose you have a patient what looks to be not an LABC but a locally, you know, big size tumor, and the patient needs some form of neoadjuvant treatment, not necessarily don't know whether chemo is required. There were two trials which got published. It's a randomized trial, but a short number trial of about 148 patients, where pre-op core is done and a MIB index and Ki67 is done. They undergo genomic profiling. Actually, at Manipal, I used CanAssist from OncoStem. And if the genomic result is low score, you start with hormone, but the recommendation is by end of 2 weeks and 6 weeks, you repeat a core and look at the MIB index falling down. in those patients, they fared better than neoadjuvant chemo. But remember, it's not a level 1 evidence to short phase 2 small number RCT, which is very important to know. So one way to know in this patient where, to do or not is to repeat a core after a course of hormone therapy, because in hormone therapy, we know it takes 4 to 6 months to have a good response, to achieve a good, but by end of early, if the BIB index is falling, then probably hormone therapy would be enough. Otherwise, chemo switchover would be required. But it's not a high level evidence, but there are 2 papers which people can go back and read. You can see that.
Two things here. One is that Ki67, I would not give much value to, because that is something which is have been a lot controversial. And also repeat sampling and this decision making will be a bit too dicey. Yeah.
Correct. It's not a high level evidence. In a patient, I have done can assist when they totally decline chemo, even though when the score is high, then I just do. Then I definitely say you cannot take this.
One scoring system people use when people get neoadjuvant hormone therapy is called PEPI score, where they look at ER downsizing, Ki67 change, nodal status, and primary tumor size. And the score is high, then these patients have high risk of recurrence. So those are the patients who end up getting chemotherapy because probably hormone therapy was not the best option. So in clinical trials with AI or tamoxifen, PEPI score is commonly used to assess the response and the prognosis for people who get neoadjuvant hormone therapy.
Correct, I agree with you. Actually, in those 2 trials, when hormone therapy was used, repeat core and fall in Ki67 was used, and if the fall doesn't happen, then neoadjuvant hormone was discontinued, and they found that chemo was required. Now, can I request Dr. DG Vijay to go ahead with this? We can have this slide.
You change the case, whole thing is changed totally. The beautiful cases there are like this occasion case.
Vijay, over to you, and then we have Sanjay Sharma's case at the end of it. Again, he has shared a couple of interesting slides. We'll go back to that. Vijay, for you.
So you can take control of the slide, sir. So you can just move your mouse, press enter, and you'll be able to take control.
Okay.
Yes, sir.
Meanwhile, until Vijay is speaking, there are 2-3 questions. Number one, what is the fate of intraoperative radiotherapy in India? I know that the only person who has used IVRT so far is you. But now with the new machine, Harit sir, and in AIIMS and in Jejjer coming, and even at Manipal, we are going to take IVRT. What do you think is the future of IVRT in India? Number one.
Dr. Sanjay should answer this first. I think he is the one who has used it. So my take is that definitely it will come into practice. There's no reason why we should doubt that. Anything which is going to give good results will finally get established. So there's certainly scope for it.
As you know, we have done almost about 52 cases started in 2011 to 2000, now more than 7-year follow-up. We have only one case in which there was a young lady, and we had not really classified the case as what target 1 and target 2. Actually, I combined all the cases depending on their logistics and the necessity for breast conservation and time. They didn't have time, neither money or energy to go and to take for their logistic reasons the entire breast radiotherapy. So there's only one got a record. We had to do a local surgery again. But practically all patients, except 2 elderly lady with their non-breast cancer mortality, rest all patients arrive disease-free. So I think it's a very good tool, especially our patients who cannot go for 3 weeks, even 6-7 days are bad. So you should just give 2 days stay in the hospital and you can send them. But obviously, it has to be a reasonably good biology. You can't use probably triple negative. But in that case of series of mine, I've used in 2 young ladies with triple negative. Of course, I had to force them to take, one girl had bilateral cancer. We had to give them external radiation therapy as a boost for just about some 10 fractions or 12 fractions. But they're all alive without any recurrences. So it's a very, very good tool. And I'm convinced that in India, especially in villages and all, where they don't have big machines and all those high-end radiation linear accelerators. India, this is a very, very good thing for local control, definitely.
I think Dr. Sushil should give us his insight into it.
So like the data, the way you look at it, did not meet the non-inferiority endpoint. So our society, both ASTRO and ABS, when they came up with the guideline, they said for a low risk population, it should be done on the clinical trial. So there are people doing IORT, both the target therapy and the ZOC electronic brachytherapy, but they are being done on clinical trial or registered trial because the data suggests the risk of recurrence is higher than what it should be. Whether it's clinically significant or not in that category is a matter of discussion. So it's worth exploring as part of the registry trial. It has some role for sure, but right now we are not offering routine. I mean, we did have IORT for some time. We were offering on a registry trial. We have stopped it for logistic reasons, but that's our stance at this point for IORT for early stage breast cancer.
So one interruption. I got a mail just now about a day back from our friend Jayant Vaidya, and this now but 3,968 cases, 38,000 cases rather, and it's 287 countries and participation. So, and they have suggested in this case that the local recurrence rate is far less, and the results have been better than his first publication when he had given about 3,000 cases earlier. So I maybe forward this to you guys. It's just gone for publication.
Sure.
That's today.
That's nice, and news is good. Hope once the full publication comes, once it is critically analyzed, it would be fantastic. So over to Dr. D.G. Vijay. Go ahead with your case.
So this is one of our own staff members, and she's a 40-year-old team member working with us. Next. She had some discomfort in the right breast upper outer quadrant since October last year. Mammography and a sonography was done at that point of time. She had been examined by our gynecologist, and somehow these symptoms persisted, and about a couple of days back, she had a right nipple discharge. It was clear in color, and there was no blood. Even at that point, she was slightly reluctant being working with us to undergo an examination, but because the mammography was normal and reported as fibrocystic breast condition, we probably thought that it is related to that. Next. She continued to have the nipple discharge, and we went ahead and got a cytology done. It was done a previous time also. There are a lot of guidelines to say that lady with a fibrocystic disease with a clear discharge, of course, a clear discharge could be pathognomonic of some malignancy, but blood-stained and serosanguine. But it could have few atypical ductal cells, and the cytologist raised suspicion of malignancy. Next. So please go back to the previous slide. These are the findings of the mammography, and the next. Because her symptoms persisted and now the nipple discharge was showing the cells which are suspicious, we got a MR mammogram done, and that showed a ductal ectasia in the right breast at 10 o'clock position, and it even showed a centimeter-sized homogeneously enhancing lymph node in the right axilla with a thickened cortex, which was reported as suspicious in nature. Next. A segmental non-mass-like enhancement, and they suggested that it could be a atypical ductal hyperplasia because she was a 40-year-old lady, or could be a DCIS, a BIRADS 4 on MR. Next. Because it was not seen well visualized on a conventional mammogram, we decided to do a digital mammogram the next day, and that showed clusters of fine pleomorphic microcalcification in the upper outer quadrant of the right breast on mammography. And the node continued to be reported as suspicious. Next. So this is the area of microcalcification that has been shown in this particular mammo. Next. Her other metastatic workup were normal. The family history was not very strong, except that her paternal grandmother had ovarian cancer at the age of 73, and a couple of her other relatives had a lymphoma and a leukemia, but they were pretty, further down. So we have going to consult a genetic expert on this next, whether she needs to get a BRCA done or not. Because the lesion was not very well visualized on ultrasound, and we didn't have facility for doing an MR biopsy at that point of time, we decided to do almost for probably the first time, I think in my career, I must have done a breast surgery without a preoperative biopsy. We decided to when I examined her, there was a palpable lump in the right breast upper outer quadrant. Through a circumareolar incision, we excised that entire specimen and sent it for a specimen mammography. And this next, and the specimen mammography reported that all the margins were clear. Because having a look at the specimen mammogram, can you go back to the previous? We felt that there could be areas of DCIS, so we proceeded to do a. We had already done blue dye injection, and we decided, because we didn't want to subject her for surgery again, we decided to do a next sentinel node, and that single node came positive. As it often happens in clinical practice, one of the nodes came positive, and there were some large nodes also seen along the thoracodorsal pedicle, and we eventually did axillary dissection. Next. So the tumor turned out to be, can you go back to the previous slide? So the tumor turned out to be about 25 millimeters in size. It's a grade 3 tumor. There is DCIS present, and it's a single focus. Next. It was also positive for extensive intraductal component. All the margins were free, and we had gone right down to the pectoral fascia, but none of it was involved. Next. The margins, as you can see from here, were adequate and uninvolved by invasive carcinoma or DCIS. Next. The single node came positive, and eventually all the 24 nodes were isolated, and out of which only a single node turned out to be positive, which was about 5 millimeters in size. That was the size of the metastasis. Next. Next. ERPR HER2 new was done. ERPR 70%, PR 10%, HER2 negative, and a Ki67 40%. Next. So the questions, because she is one of our own colleagues and works along with us, so she has also been consulting a lot of people, we assume. And so whether there is any need for revision surgery at this point of time, because with extensive DCIS, EIC component, need for confirmation by FISH, because somebody told her that, 1+ also there could be some, FISH could give a discordant result. Role of genomic assay, role of if chemotherapy is indicated, whether 4 cycles or 8 cycles, hormonal therapy, radiation, and follow-up strategy. The case is now open for discussion.
Okay, see, before I throw it open to others, now there are following risk factors. She is a premenopausal still, right? 40.
Correct.
Premenopausal, number one. Even though you achieved a negative margin, beautifully localized before, you had an MR mammogram, and you had an intraoperative mammogram control, and you also have a very good pathological. Young lady, premenopausal, and the second thing is extensive intraductal component. By initial trial, if you see JCRT trials, these patients would probably have something like in excess of 7 to 10% local recurrence in spite of the best surgery. But we'll ask Sushil what it happened. This is number one part, that revision of margin is not required, because if any extensive intraductal, should you go for mastectomy with immediate reconstruction, or you take the surgery adequate and then still go for a radiation? Number one. FISH current recommendation, definitely one is not recommended.
I agree to that.
Most of the genomic assay, except 1 or 2. So if you see that the Canasis, this is also was found to be useful in premenopausal Indian women. Otherwise, when you look at Oncotype or Memopride, they are not very sensitive for premenopausal. But 2 of the genomic assay, because she still fits into the criteria, less than 3, early T2 tumor, and ERPR positive.
Node positive, grade 3. So I think a lot of things.
Positive up to 2 to 3, you need to look at it. Not everybody has got an approval. So in a young lady with that, genomic assay, it is a gray area, it's not a high level evidence. So in all probability, she would definitely go for chemo. Most of them would actually probably use 4-AC by Packley. But I will throw it open to Sushil first, and then to Sanjay Sharma and Harit. Even though it is a good surgery, just because she's a premenopausal young lady and extensive intraductal component is there, how comfortable and happy you are to continue with breast conservation RT, or would you offer a mastectomy with reconstruction?
So, like EIC with negative margin is not a contraindication for breast cancer therapy. Like there are multiple studies which have come out and said EIC is is, as long as you get negative margin, the breast ipsilateral breast tumor recurrence after lumpectomy radiation are same. So I do not consider EIC as a factor as long as margin is negative. And she had good margin, so I would ignore the EIC component and just offer adjuvant radiation therapy because she has no contraindication for breast conserving therapy. The only thing I would do extra is because she has multiple adverse factor, like LVSI, grade 3, T2 disease, and macromets. When I treat based on MA20 and EORTC, I would also treat regional nodes. So I'll treat breast and regional node, undissected axilla, supraclav, and IM node along with the adjuvant breast treatment.
My question to Sushil and to Rishi is whether she is at higher risk for intra-breast tumor recurrence because of this EIC.
So let the physician answer first.
So you mentioned that the invasive component was 25 millimeters, right?
Yeah.
Vijay? So what is the total size, including the DCI's component? Is it same or any bigger?
The size, it extends for about, the size of the invasive component is about 25 millimeter, and the size of the DCIS is around 1 centimeter.
So it's not massively different.
No.
Sorry, I can't hear you. No, I don't think there is any indication for doing any more surgery for breast. At least she has a very good margin. Now we would accept any margin more than 1 millimeter for invasive and possibly 2 millimeter for DCI. So she has a very good margin. I don't see any reason. She certainly wouldn't have any survival benefit from doing any further surgery. She might have slightly higher risk of local recurrence, but that's true for any breast conserving surgery. The question you'll need to ask is that what have we removed? I mean, this is one of the very difficult cases to get that. You didn't have any, I believe you excised a lump, right?
Yes.
So, and that seems to include the trouble area, at least the calcification she had. So I would be quite keen to, did you say you have done axillary dissection after that? Or she
Yes.
had axillary dissection?
Axillary dissection.
So she doesn't need any surgery. She certainly will need to be considered for systemic chemotherapy and an endocrine treatment. I'll be quite keen to follow her breast with MR scan for various reasons. One of them would be the uncertainty about what actually was the true extent of the disease, because it was a non-mass enhancement with a possible invasive component. So I think it fits into the picture of what MR showed, but it still will be a good idea to follow it up with MR scan, at least for the first few years.
Okay. Sushil, you had to say something?
Yeah, Sanjay Sharma, sir. Yeah.
Sanjay Sharma.
No, I think an excellent job, Vijay. I would definitely do what you did. I think at this stage, no surgery. You've done a really good job. Hopefully, cosmetic issue looks as good as
Okay.
would be doing all your cases too. I have slight difference of opinion with for the radiation. Say the axillary dissection was the microscopic metastasis. I would still give her chemotherapy 8 cycles, but I will not radiate the axilla at all. I would hold on the radiation because it's absolutely a microscopic disease, and I will give the whole breast radiation and continue her for anti-hormone therapy for maybe long period of time. Yes, you may have to consider her even later on for very frequent follow-up with an MR because young lady, and early recurrences are there, but I would suggest there be more local recurrences. So anti-hormones will take care of all that. So I think you have done a wonderful job, and I don't think that young age is the only criteria for us to do a mastectomy. I think the bar is still in our favor.
I agree that there's no clear indication for axillary radiotherapy. She had axillary dissection, and she got the solitary nodal involvement. So
You're not talking about axillary radiation. You're not talking about axillary radiation. When we look at MA20 and EORTC trial, somebody had 1 to 3 Mets and high-risk features. The targeting is undissected axilla, so which is level 3 supraclav and IM node. We never treat dissected axilla because there is no value treating the dissected axilla. It adds to the lymphedema and it doesn't add to the local regional control. So I'm talking about undissected axilla, supraclav, and IM node.
Okay.
Agreed,
That's fine.
agreed.
That's fine.
Point taken, sir.
Vijay, there are two questions. One is, the lesion was 2.5 and then another 1 centimeter, and you removed a specimen of 7. So Dr.
Yeah.
Manjula is asking what type of oncoplasty you were able to do, even though I know you had done your good, you did some sort of local oncoplasty, rotation, flap,
Local advancement, because the volume of the breast was quite large, we have been able to mobilize both the pillars and do a local oncoplasty, almost a level 1 oncoplasty, even though the size of the defect was quite big.
Second thing, what is being asked is, this patient had a nipple discharge which showed atypical cells. So there is a concern and a question by the delegates. So you left those ductal complex which showed a nipple discharge which was atypical. So are you okay with that? And there is a question. So what is your thought process on
that? We have taken a circumareolar incision and excised the entire lump, which was in the upper outer quadrant, right up to the nipple areola. So I think that should take care of the, that is a question that whether the ductal discharge was primarily from a lump which was located slightly away from the nipple areola complex itself. So the nipple discharge doesn't necessarily mean that the duct itself was involved. The duct at a distance was involved. So as long as you remove the duct leading up to the nipple areola complex, then you will be able to achieve negative margin.
Good. Anything you want to add, Harit sir?
Yeah, okay, fine. So two things here. One is that whenever we do find a lesion in the MR, it is better to go back and do a re-imaging with ultrasound. Often we can do a biopsy. As Dr. Vijay said, the first time he went ahead and did a surgery without a biopsy. So I think because we feel handicapped that you don't have an MR guided biopsy tool, so that should not be. If you go back and re-evaluate, quite often you're able to see the lesion on the ultrasound, and that is a very good lead to take a biopsy.
A second look ultrasound.
That is very important.
Agreed.
Whenever you have in a proven situation, we always do an ultrasound axilla guided FNAC. Suppose you had a biopsy for the axillary node because you finally got a node positive, and yours on the MR also it showed a suspicious node. So I think that's another thing I want to say.
I think we could have considered a stereotactic biopsy of the calcification.
Sometimes, yeah. First is ultrasound, then a stereotactic. So ultrasound is more simpler to follow in the OPD. So actually also is possible, definitely, but that is the general
ultrasound was normal. There wasn't any anything visible on ultrasound scan, Vijay.
Somehow it was not well appreciated on the ultrasound, and
on second look ultrasound it works very well actually.
Very well.
Yeah. And axilla should always be sampled. Whenever we do so axilla, when in fact Rishi was mentioning about clinically node negative, I am assuming that clinical node negative means ultrasound included, because we always do an ultrasound and also whenever possible in FNAC. So that is one point I wanted to make. Second is, as far as nipple discharge is concerned, any lesion can lead to a nipple discharge. So when you do a surgery and cytology was done, so we have to just keep this under follow-up by regular imaging.
Preferably by an MR.
Preferably by an MR.
That was the lesion that first detected okay.
Agreed.
Okay, so what I would do is we'll open for question and answer because a lot of questions are coming from the delegates participating. What we will do is I request, because we already overshot by 30 minutes, we may have to end up a little early. You raise an hand, and Kashish, you can just selectively unmute them and be precise with a question and to which panelist or speaker you are asking, and then only those person will unmute. So we go with the short question and answer session. So Kashish, can you just unmute the people who raises the hand and take it selectively?
Sure, so we've received a few questions. Can I ask them to? Yeah. Can I ask Dr. Neha Chaudhary to ask her question? Ma'am, I've unmuted your mic. Please go ahead.
Hello, everyone. Sir, a wonderful session. My question, sir, is that in the era where we have just come to know about fast forward, now where does the applicability of ACOSOC Z11 stand? Because if we're de-escalating radiotherapy, is ACOSOC Z11 still safe?
I think Sushil should take this.
So, like there are, the fast forward had two components to it. One is a breast only treatment the other is a regional nodal treatment. So they will present their regional nodal treatment data at some point later on. And that will give us some answer about whether it is safe to do regional nodal radiation therapy with that dose fraction or not. Currently, if somebody meets G11 criteria, we do hypofractionation, 40 grain 50 fraction, including level 1 and 2, and boost the surgical bed. But fast forward does have a component of regional nodal treatment, which will come out at a later point. If it allow regional nodal treatment, the same dose of fraction, we'll have the data when it comes out.
Thank you, ma'am.
Yeah, thank you, sir.
Yes.
Thank you.
Can I request Dr. Vaishali to ask her question? Ma'am, please go ahead.
Yeah, thank you, sir. This is a question to Dr. Sushil. As far as fast and fast forward trials are concerned, I'm wanting to know about the effect of these type of fractionation schedule on the cosmetic outcome, especially in oncoplastic breast surgery, especially the complex surgeries like therapeutic mammoplasty. Do you feel that these are applicable to these, the high dose per fraction and hypofractionated schedules like fast and fast forward? Do you think that a cosmetic outcome would be good in complex oncoplastic surgeries?
So let me give you, we have to unmute it. So let me give you my perspective. In the fast forward trial, they had about 8% of the people who had mastectomy and some of them had reconstruction done. It was a small subset, but they did not report any adverse outcome. Very, very important thing which I emphasize, that the dose homogeneity has to be met. Right. As long as you're able to meet dose homogeneity, you will see less skin toxicity and similar cosmetic outcome. Okay. But if you're not able to meet dose homogeneity, then you have to either scale down or do something to meet dose homogeneity, because if you can't, then the impact of dose per fraction is higher. So I do not consider oncoplastic to be a contraindication as long as we can achieve homogeneous dose distribution, which we achieve with two techniques, either field within the field or sometimes tangential inverse planning. And either of the two techniques will help you out.
Sure. Thank you, sir.
Thank you, ma'am. Thank you, sir. Can I request? Sorry, yes, please go ahead.
Raised their hand. Kashish, Dr. Geeta and Neeraj Gupta maybe raise their hand and just check their question.
Sure, sir. Dr. Geeta, I've unmuted your mic. Please go ahead.
Yes, actually, my question is they have already answered the question, but I want to know when discharge is positive fetal cells, where you, at the edge, at the nipple, at the further end, whether you are taking the margin and sending for frozen section or separately margin and sending, whether to know whether we don't know which end it is positive, no?
Okay, see, actually, Vijay answered this. Maybe I'll get an expert comment from Rishi. The issue is there is a nipple discharge which was cytology positive, and then it is not like you're done a Higginson or a complete duct complex. So, Rishi, what is your take? Crisp and clear.
I can see what the concern is quite valid, and particularly it becomes even more complex if it's not a complete preoperative workup. It was done with some constraints, and an excision biopsy was done. Now, Vijay said that he took the dissection to nipple, and if you were faced in that situation, then a nipple shave should be taken and it should be orientated properly and sent separately for examination. It is very difficult, if you're operating and you find incidental cancer on excision biopsy, you don't have many recourse. But it seems that he's been very clever in taking the ducts to nipple and sending the specimen. Is that correct, Vijay? And if that has been done, then I'll be quite happy with that histology if that's negative. If we had concerns to start with, if there's someone who has nipple discharge and we go in and do a breast conserving surgery, we'll always try to take a nipple shave and send that separately with proper orientation. And mostly these are cancers periareolar in position. Don't expect, usually it can happen, but you don't expect a deep cancer far away from nipple areolar complex presenting with nipple discharge. So it's often possible when you were doing a surgery with circumareolar incision or approachable incision to take a nipple shave if you have any concerns.
Thank you, Rishi. That's very well added. In the constraint of time, this will be the last question we have now. Neeraj Gupta, please unmute him, and that is the last question, and we would have to end. All good things have to end. Then, so this is the last question. Neeraj.
Sir, this is Neerja Gupta. I'm from Delhi, and thanks for the informative session. So I've got two questions. First, what is your take on NEHT versus NACT in an oligometasis in oligomets setting with a luminal A patient post-menopausal?
Sanjay Sharma sir should take it because that's an excellent work done from him.
If it is a luminal A case, it will depend on the age of the patient as well.
Post-menopausal, sir.
Post-menopausal, and oligometastasis to which organ you want to know. So if it is to the brain or to the soft tissue area, I would...
lung nodules.
Sorry?
Lung nodules.
I had that case I mentioned. So this patient received 4 cycles of AC followed by Peckley carbo. And then we did the primary surgery, and then the lung was observed for some time because it remained static for quite some time. And then after about 8 months or so, on tamoxifen, on letrozole, that patient of ours, we had to go down and do a mini thoracotomy and excise those nodules as it remained static, and we wanted her to be disease-free. It was positive on the PET always at 2-3 occasions that we followed her up.
Okay, right. Thank you, sir.
Thank you. That's excellent. Yeah.
Am I offered a second question, a short question, please?
Yeah, quickly, short question.
Yeah, quickly. So this is about Z11. So when you talk about an axillary treatment, so we are still waiting for the post-hoc results, we all know. But if we go ahead with axillary treatment, surgery versus radiation, with the literature, we see that the person or the lady who's given an axillary radiation has a lymphedema score of as good as 23%. And with surgery, with good hands, the lymphedema is 15%. So what is your choice or what is your take? Would you offer an axillary radiation or would you offer an axillary surgery in a patient who fits into Z11, a post-menopausal lady?
Okay, who would want to take that? Rishi and then Sanjay Sharma.
Sir, I'll just unmute your mic 1 minute. Yeah, go ahead, sir.
So I'm just clarifying the question. The question is that if someone who has a low volume disease, what is the advantage of offering radiotherapy, axillary radiotherapy in preference to axillary dissection? Is that the question?
Yes, exactly. That's the question, sir.
So the question, I think you got the data for long-term morbidities probably other way around, because Amaros trial showed that completion axillary dissection would have 25 to 30% incidence of long-term morbidity, whereas axillary radiotherapy will have about 15%. So that's an argument in favor of axillary radiotherapy. But Z11 is about omitting further axillary treatment at all. So, if you're looking at an appropriate case, and I'm not recommending this because it's not even a routine practice in the UK, but if you want to select an appropriate low risk case, you could actually consider omitting any further axillary treatment, whether it is completion axillary dissection or axillary radiotherapy. So that is what Z11 is about. But radiotherapy has lesser morbidity in the long term in low volume axillary disease treated.
Sorry, but I would differ a bit on this, because if you collect data worldwide, when you talk of MROS, it's way back. And with the refined techniques, use of cautery and lot more things, and sentinel node, the lymphedema rates they have definitely come down. And with the understanding of developing lymphedema, which regions to encroach and which regions not to encroach, we are on about less than 13% of lymphedema in ALND patients and almost as good as 0 in SLND patients with our center.
Okay,
so
I
would
have to interject. What happens is the personal experience sometimes vary, and in a short cases it looks good. But the beauty of a large prospective multi-institutional randomized trial is surgeons come in all size, shape, and all patients. So what is applicable across the community? So when we really do a trial, what trial shows is actually the real world time. I would say, Sushil, give a last parting comment on this, and then we end the question answer. Sushil, your take on this question?
So, like as somebody is saying that after sending for biopsy, what volume to treat, how much to treat is very, very confusing because of Z11. Z11 didn't want to do anything, but some people ended up treating the axilla. The MROs treat everything comprehensively. The IBIG trial for micromettes didn't do anything. So we do not know what amount of axillary treatment has to be done. But one thing is for sure, as pointed out by the previous speaker, but somebody with 1 or 2 metastatic disease, whether it is micromets or macromets, don't need any more additional surgery if they have lumpectomy done. How much radiation to do is a question of like individual preference and what guidelines you have. Like at our institution, at UPMC, we have defined guideline. If somebody has micromets only and have lumpectomy done, we treat tangential beam, including level 1, level 2 nodes. We don't treat comprehensive nodal treatment like MROs in those patients. If somebody has macromets and 1 and 2 nodes, then we treat at least 1 and 2 and add level 3 and supraclav if they have adverse factor. So to make practice uniform, that's our guideline. And we publish that by using the guideline, we have 80% concordance rate of practice pattern in the country, in our network, which is about 25 sites to make it uniform. But if you ask different people, they would have different answer. But one thing is for sure, as mentioned, for somebody with 1 or 2 mets and has lumpectomy done and is going to get radiation therapy as part of the care, should not undergo dissection in 2020.
Thank you. Actually, we have to end the question and answer session. That was excellent. We have actually a very good one more case from Sanjay Sharma. For the want of time will not be possible, but I request him to please give a conclusion remarks and take home message before I hand over to Dr. Manjari, CEO of Oncos. Sir, over to you.
Yeah, first of all, thank you, Manjari and the team. It was really a fantastic. Unfortunately, I had, for some personal reasons, I'm not sure whether the proper slides went to you. Unfortunately, the other set of slides was sent. This slide, we sent it just now. But anyway, this session was very, very nice. And I really thank Som to chip in for me because of my personal problem. I couldn't be ready for that. And luckily, I could at the end, at least attend this and participate very well. And I'm really enthralled to listen to all my colleagues around and an interesting question asked. And again, thank very much Dr. Manjari and his team to have done a wonderful job. We still have many, many more such meetings will be there, and we have hundreds of cases to discuss. So I think we'll wait for the next time too. Thank you.
Sure. Thank you all for this wonderful participation. This is Manjari speaking from OncoStem Diagnostics. It was really a wonderful session, and the participation was just really excellent. So I really hope it was extremely informative for everybody as well. It was certainly for me. So with this, I conclude this session. Good day to the faculty joining from US and UK. And good evening to everybody joining here in India, and special thanks to all of our panelists and faculties for this wonderful session. Extremely informative and very well discussed. Thanks a lot again, and have a good night.
Thank you. My special thanks to Sushil and Rishi and Sanjay Sharma sir. I just know how much of personal difficult day he had, and he still managed come and then do. I personally thank him, and Harit sir and DP Vijay and all of you for excellent interaction. Thank you very much, and I thank OncoStem for hosting this and facilitating such an academic feast. Manjari, Vishwa, Manoj, and the entire team, and thank you very much. And also I thank Kashish and his team for doing fantastic work. Thank you.
Thank you, Kashish, for the fantastic organization. Appreciate it.
Thank you so much, sir. Thank you, ma'am.
Okay. Thank you. Bye-bye.
Thank you.
Sure.